Good evening everybody, and it's a pleasure to be here on this webinar here, and I hope you all can hear me well. A lot of preparations have been done to run this without a glitch, and thank you for being with us. Today's topic is about how do we use cell-free DNA screening better. So I'm sure a lot of you use this technique and you've been incorporating this in your routine screening protocols. We will try to see what we are doing well and what could we do better, and what more could we do with this technique, which seems to be a very powerful tool in our armamentarium. So basically, let's start with the basics. What exactly is cell-free fetal DNA? Now, it's DNA which comes from fetal or actually placental origin. It is cell-free because it's lying in the maternal circulation as DNA without being covered inside a cell. Why does that happen? Because some cells migrate into the maternal circulation from the feto-maternal interface in the placenta, and by apoptosis these cells are broken down. Their DNA is lying free in the maternal circulation. Now, while maternal DNA in that circulation would be about 90%, about 10% is expected to be of this non-maternal origin, which is presumed to be fetal DNA, and hence it is called cell-free fetal DNA. So in 1997, the presence of this was reported, and this DNA comes from the placenta. It's known to be detectable after 10 weeks of pregnancy, and it's rapidly cleared away from the circulation after the delivery of the fetus, such that once a pregnancy has been cleared off, the remnant of that fetal DNA in the maternal circulation is not expected in future pregnancies. So it's come to be known now that maternal blood becomes a reliable source of material for prenatal fetal DNA based screening. So it can be done on maternal blood, as we said, anytime after 10 weeks of gestation, and all that is required is about 20 ml of maternal blood. And it's a very good screening test for screening for trisomies in the fetus, especially trisomy 13, 18 and 21. The sensitivity that is claimed to be more than 99% with this kind of a screening test. The other uses of cell-free fetal DNA could be to guide management of women who are rhesus D negative, because on the same DNA of the fetus, fetal rhesus typing can be achieved. And if you know that the fetus inside a mother who's rhesus negative, even isoimmunized, is rhesus negative, a lot of unnecessary surveillance can be done away with. Similarly, fetal sex determination could be done in indicated cases where there are sex-linked diseases, genetic diseases, and the sex itself poses a high risk, where in India specifically, where there are legal implications and permissions for the same. Now, how is that done? Fetal DNA is first identified, and once it is identified, it is read by two specific techniques usually used in this thing. One is called massive parallel sequencing, that is, a lot of copies are made up of a particular DNA fragment, and you identify which is maternal, which is fetal, and then you compare the DNA material in the of the fetal origin to the maternal origin, and assuming that the mother is normal, you report whether there could be a presence of extra genetic material, extra DNA material relevant to a certain chromosome, and therefore you report the high probability of having a trisomy. This has also been used for analysis of subkaryotypic or subchromosomal problems like microdeletions and mutations, although the validation is still pending. Single nucleotide polymorphism counting is another method of looking for the fetal DNA in maternal blood, and the advantage it has is it can work in even very low fetal fractions, although it cannot be used for certain specific indications which massive parallel sequencing can be used for. So either of the two techniques is used while evaluating the cell-free fetal DNA. The important bit is that the fetal fraction should be 10 to 15% at least, so that your results are very valid. Otherwise, your chances of being false negative is also very high, and the whole point of this test is to have a very good negative predictive value. So when you compare the cell-free DNA testing in terms of its sensitivity to detect a fetal trisomy 21, It's actually amazingly high, more than 99%, as compared to all the other methods of screening, which can range from anywhere from 50 to 80% or 90-95% when you combine it with the high level nuchal translucency scan, where all the other fine markers are also taken into account. So this becomes a simple blood test which gives you a more than 99% sensitivity for screening for Down syndrome. Looks pretty promising, but you need to look at the whole picture. So the other method by which we could definitively tell people about the confirmation of trisomy in the fetus is invasive testing, of course, and the advantage is it's almost 100% confirmatory, but the disadvantage is the procedure related risk of miscarriage, and that seems to be a big disadvantage when you are thinking of the whole population. So cell-free DNA testing allows to have a very good sensitivity in terms of screening for this aneuploidies without any invasion of the gestational sac, and therefore no added risk of miscarriage. Test is done on fetal DNA, so it is almost gestation independent and highly sensitive. So let us look at this case. Mrs. A is 6 weeks pregnant. It's a single live fetus. She is checked on the scan, and she is 42 years. This is her second pregnancy. The first child was delivered 11 years back. She suddenly got pregnant. She didn't plan for this pregnancy, but now she wants to continue as long as she can rule out trisomy 21 as best as possible, as soon as possible, and preferably non-invasively. Now, having heard the background just now, she seems to be a good candidate to do the cell-free DNA test because she is 42 years of age. She is now 6 weeks pregnant, and the options for ruling out trisomy 21 would be first traditional screening, or do a CVS or an amniocentesis with a risk of miscarriage, or cell-free fetal DNA. Now, if you look at what she wants to rule out trisomy 21 as best as possible, as soon as possible, and preferably non-invasively. You could offer her a non-invasive testing, that is a cell-free DNA testing. And yes, it was done, and the risk and the report came as very low risk for trisomy 21. So when it said very low risk, it doesn't necessarily rule out Down syndrome completely, but knowing that this is done on fetal DNA and it's got a great negative predictive value with a sensitivity of more than 99%, she could be advised that she does not need an invasive test, and that is a big advantage in this case because it's got a very good negative predictive value. In her case, with a 42-year-old baseline age, conventional screening may not have performed that well, and she managed to get very early reassurance with very good sensitivity. Now, this is a 32-year-old lady, IVF conception, now 14 weeks, and this is her 4th pregnancy. Unfortunately, all 3 previous pregnancies ended in early miscarriages. In this pregnancy, traditional screening was done with the combined first trimester screen. Her NT scan was normal, although uterine artery Doppler PI were raised, but her combined FTS gave her a risk of 1 in 56 for Down syndrome because the PAP-A moms were 0.1 MOMs. And she also wants to rule out trisomy 21 as best as possible, as soon as possible, but preferably non-invasively, because the main thing here is to avoid the added risk of miscarriage. So she is again a good candidate for cell-free fetal DNA testing, and it was done, and luckily the result came as low risk. The result also reported other sex chromosome aneuploidies and some deletion syndromes, although it said in fine print there that these results are not validated, and that I urge all of you to look into these reports so that you know the confidence with which you can reassure your patients based on that report. So if you see here, the sensitivity for trisomy 21, 18 and 13 is 99%, whereas that for the rest of the other problems is less than that, and for deletions and autosomal trisomies, it's actually not validated. But the main reason for us to do the test was to make sure that she is low risk for fetal trisomy 21, which she is, and therefore the main advantage in this case was you avoided an added risk of miscarriage due to an invasive procedure and got very early reassurance with better sensitivity. This is another lady, 37 years, IVF conception, now 14 weeks, the same profile, 3 previous miscarriages, and she also wants a early reassurance, and just like the first case, we chose to do a cell-free fetal DNA. But here we were surprised because the result came as high risk. Now, this is a very sensitive test. It is done on fetal DNA and the result says high risk with a probability of more than 1 in 20. Should we just go ahead and terminate the pregnancy because she doesn't want a trisomy 21 pregnancy? Would that be a right thing to do? I can't see you or hear you, but I hope all of you are thinking in your minds what would be the right thing to do here. Because it looks like a test done on fetal DNA, it seems extremely possible that this will be trisomy 21, but still the recommendation is that this is a screening test, and if it is high risk for aneuploidies, you follow it up with a conventional karyotyping by invasive testing. In this case, the invasive testing is justified by the fact that the chance of finding trisomy 21 is more than 1 in 20, which is much more than her presumed risk of miscarriage as such, and therefore conventional karyotyping was done, and we did confirm that it was a standard trisomy 21, and the patient could go ahead and take her decision based on this. So there are these disclaimers and remarks at the end of your report, and you must pay attention to the fact that a low risk result does not possibly exclude fetal trisomy, and a high risk result should not be considered as diagnostic. So the bottom line is that cell-free fetal DNA is a very good test, but it is at the end a screening test. So before you offer this test to your patients, you must tell them that it is a screening test and appropriate pre-test counseling should be done. Now, what is the result? What is the reason that this test could be false positive or false negative, which is why it is not categorized as a diagnostic test, rather a screening test? Because in some cases you could have confined placental mosaicism. The placental karyotype may be different from the fetal karyotype per se. There could have been a demised twin inside which was not detected earlier, and the fragments of that, the DNA fragments of that twin could be still floating in the circulation. The mother could be a mosaic karyotype which she is unaware of, and maternal mosaicism can lead to confusion in reading the DNA results. Maternal malignancies could lead to aberrations in chromosomes in the maternal circulation from non-maternal, technically non-maternal origin, which can again cause confusions. Copy number variants in the mother just by chance, technical issues, or if the mother is a transplant recipient. So if you have very borderline low fetal fraction, again your results may not be as accurate, and you have to be sure that whatever results you are giving is based on a good fetal fraction. Nevertheless, all these things could cause false positive and false negative results, and therefore you have to remember that it is only a screening test. So a pre-test counseling while offering the cell-free DNA test must reiterate the fact that it is a screening test, and also that it is best validated for trisomies like trisomy 21, 18 and 13. The information on microdeletion syndromes does not have a very robust validation, and therefore there is a chance of confusion. It is not recommended to do this primarily for those indications. Whether you should extend your screening portfolio and include those conditions is a clinical decision you have to take after discussion with your patient. Any positive test must be followed by a direct invasive test for confirmation. Decisions like termination of pregnancy must not be taken based on cell-free DNA test alone. Sometimes your result on the cell-free DNA may reveal a microdeletion, and on further testing you may actually find that one of the parents is a carrier of that microdeletion. Now, if it has implications on the health of that parent or on the health insurance of that parent, there could be long-term proliferation implications of this finding, and that also needs to be considered. You may inadvertently reveal maternal mosaicisms or malignancies, and those implications have to be considered. This test does not provide any additional information about pregnancy complications like risk of preeclampsia or fetal conditions like neural tube defects, which is an advantage with the traditional screening methods. So when you do cell-free fetal DNA as a primary screening test for trisomy 21, you are compromising on the advantages of the conventional screening for these conditions. And it is not recommended to do both screening tests parallelly. So you have to devise a method where probably you could do those aspects of the traditional screening separately, not for trisomy 21, but for those conditions if you wanted to get the best of both. The accuracy of cell-free fetal DNA is limited in multiple pregnancies, but it's heartening that it's getting better and better, and we are able to offer this even in multiple pregnancies. So like every screening test, the result of a cell-free fetal DNA test is either high risk or low risk for a condition. It is not a diagnosis. I repeat, it is not a diagnosis. However, this is a different kind of screening test. Traditional screening tests are applied on a low risk population to pick up an apparently high risk population, whereas cell-free fetal DNA is a secondary level screening test which is applied on a generally high risk population to pick up the ones which are at the highest risk and therefore minimize the number of unnecessary invasives. What if you used it as a primary screening tool? It does have a higher detection rate for trisomy 21, 18 and 13. However, it is not recommended as a primary screening method for general population because a lot of research has been done on these things and the logistics have been worked out. But using cell-free fetal DNA as a primary screening tool for trisomy 21 does not seem to be effective. Whereas if you use it as a secondary screening method, assuming that there is a 98% detection rate with a 0.2% false positive rate and a 1% test failure rate, definitely there is a reduction in the number of unnecessary invasives that you have to do. So, the best location of NIPT in a screening protocol would be as a secondary screening test after the primary conventional screening test has proved positive. Now, what about multiple pregnancies? Till many years back, we were not able to offer this to multiple pregnancies, but now we are able to do this. The report looks like this, where it says negative result, no aneuploidy identified. So, this was again a patient who had high risk for aneuploidy based on the first trimester screening, IVF pregnancy, not willing for invasive, and we used the cell-free DNA because once we found no evidence of aneuploidy, we thought it was very reassuring because of a good negative predictive value. However, if there was evidence of aneuploidy, we wouldn't know which fetus was affected and hence we would have to check both anyway. But the biggest advantage is that if it is a false positive and the traditional screening is false positive and the cell-free fetal DNA report is low risk, it reduces the need for an unnecessary invasive test in this case. So, the early scientific statements that were made by governing bodies like the RCOG when cell-free fetal DNA became available as a commercial service to the general patient, it said that they thought that this is going to change the way prenatal diagnosis and screening is delivered in that country, both in the NHS as well as in the private sector, and the acceptance and the availability has consistently increased over the past few years. The American College of Medical Genetics and the American College of Obstetrics and Gynecology also came together and gave a committee opinion where they picked out a certain group of people which would definitely benefit from cell-free fetal DNA even as a primary diagnosis. So, maternal age of 35 years or older at delivery was taken as an indication where you could use cell-free fetal DNA as a primary screening method. And as you saw in the first case that we demonstrated, the mother was 42 years of age and she just wanted a good screening for trisomy 21 as her primary target, and cell-free fetal DNA fitted the bill very well. When fetuses with ultrasound findings have an increased risk of aneuploidy, also they have mentioned that we can do the cell-free fetal DNA, although there is a word of caution here that we recommend doing cell-free fetal DNA when there are minor markers on ultrasound, but any time when there are structural abnormalities, major structural abnormalities or even an increased nuchal translucency, it is recommended to go for a conventional karyotype as opposed to cell-free fetal DNA, because this only gives you information about 3 trisomies primarily. Whenever there is a history of a prior pregnancy with trisomy 21, you could use cell-free DNA as a primary screening method for trisomy 21. A positive result on aneuploidy including first trimester sequential or integrated screen or even a quadruple screen. So, basically any of these conventional methods, if they are high risk for aneuploidy, you could use cell-free DNA as your secondary screening. If the parents are carrying a balanced translocation which increases the risk of trisomy 13 or 21, again she is a candidate for primary screening with cell-free DNA because it is most accurate. So this is the suggested screening protocol for trisomy 21 in Indian scenario, where we could confirm viability and dating at 6 to 8 weeks, do the first trimester bloods at 10 to 11 weeks, an NT scan at 12 weeks, which is ideal if you do the biochemistry early and the NT scan around 12 weeks. And the ones who are low risk, they go into the routine anomaly scan where genetic sonogram is a part of it. The ones who are high risk have the option of either confirming the karyotype by CVS at that point, or going on for the next level test by a quadruple test at 16 weeks. Again, this was the traditional way of screening, and again after the second trimester assessment, the low risk group goes into the routine care, whereas the high risk group can have the option of confirming their fetal karyotype by amniocentesis or fetal blood sampling. Where NIPT comes is in between this, where the traditional screening has said high risk and you still want to avoid the an unnecessary invasive, the low risk ones on NIPT could avoid that invasive. So NIPT helps in reducing the invasive testing in women who are screened positive to for trisomy 21 through conventional screening tests. Now, the meta-analysis on this test said that screening for trisomy 21 by analysis of cell-free fetal DNA is superior to all other traditional methods with a higher detection rate and a lower false positive rate. And the performance for screening for 13, 18 and sex chromosomes is a little worse than trisomy 21. So, for trisomy 21, it is highly validated and a very sturdy screening test. But don't forget the whole fetus in the quest of just trisomy 21. So what is important is you should not think that your first trimester scan becomes redundant once you've started using NIPT for primary screening of trisomy 21, because a routine anomaly scan, a scan to check whether the baby is growing well or not, is extremely important in the first trimester. So even if you have done your screening by your cell-free fetal DNA, there is a place for the first trimester detailed anomaly scan. The scan is anyway warranted, and if you are anyway going to do the scan, why not do it in a better way and make it as a cost-effective screening? That is the reason for primary screening in the general population. An NT scan with combined test works very well, much better than the NIPT in the larger picture. So the thing is, even if NIPT is so good, if it's high risk, you still need an amniocentesis. The good news is the risk of miscarriage on amniocentesis, according to this meta-analysis, is actually very low now. So with such low risks of miscarriage added because of the procedure, doing an invasive test after a screen positive test is not really the end of the world for the patient. Now, when we should not be recommending the cell-free fetal DNA test is, suppose the parents want 100% confirmation of fetal karyotype. You can't do that with NIPT. It's only 99%, and that too only for major trisomies. So if they want 100% confirmation for fetal karyotype, an invasive direct testing is the answer. When there are major structural defects in the fetus, direct invasive testing, not only for karyotype, you may also need to do cytogenetic microarray, but little more than what cell-free DNA can offer. If there are known karyotypic aberrations in the parents, like translocations elsewhere, you may want to do a complete fetal karyotype. And presently, it's still not available for single gene disorders in India. The validation processes are on. There are a lot of claims happening there, but we still have to see that they are validated and can be offered routinely to all patients. Now, sometimes there could be problems, like you could get stuck with non-issues. This was a patient who opted for cell-free fetal DNA primarily because of advanced maternal age and a previous preterm delivery, such that she didn't want any risk of invasive in this pregnancy. And surprisingly, her result came normal for fetal trisomy 21, 13 and 18, but for sex chromosomes, the report said the fetal DNA is in a non-significant range. And we repeated the sample because we thought maybe they got less fetal fraction, but despite all that, the anxiety continued because the repeat sample also said that it was in a non-significant range. And they very clearly said that we have repeated this twice, and there is no point repeating it again. There is no way we can find out how the sex chromosomes are. And this led to unnecessary worries because we were not concerned about sex chromosomes in this case in the first place. Now, Could we use this as a reason to do sex determination if we did an invasive test based on our present PCP&DT regulations? Nobody had a correct answer for it. Could we completely reassure her? No, we couldn't, because there is something which is not so correct on the screening test. And do we still have to do an amnio? If yes, what is the consensus on the sex chromosomes? So despite all these questions going on in our mind, the patient was very clear, and she decided that, look, I didn't want to look for this in the first place. So she made life easy for us by saying that we don't want to check anything further, let it be. Luckily, the child was born, it was a female, and the postnatal karyotype was completely normal. But we got completely stuck with that report for some time. Similarly, this is another patient where a quadruple test was done. The risk was 1 in 104, and she was extremely scared about an invasive test, so opted for non-invasive testing. And again, the report was like consistent with 2 copies of chromosome 21 for the trisomy 21, for which she was high risk, but the result said aneuploidy suspected, and that too Klinefelter syndrome, result consistent with the presence of an additional X chromosome. Now, in this case, we used this as a reason to do an amniocentesis, and the fish reported normal fish, including sex chromosomes. So, although sex was not revealed to the baby, to the mother, at least we knew that there is no sex chromosomal abnormality there. So, did it help or did it not help? It's both ways, because on some grounds we got some reassurance, but we were stuck with some issues that we were not really looking for. So one particular question is, should we have an option to look only for trisomy 21 on a cell-free DNA test? And would that actually make the test also cheaper and make the counseling less cumbersome? And we would not get stuck with all these issues. So that's one option which we should look at some point. And the pre-test counseling has to be done to decide whether or not to opt for any test, and a post-test to be done what to do with the results of the test. The other use of cell-free DNA could have been to solve the rhesus puzzle. Now, we all know that when a mother is rhesus negative and she is carrying a fetus who is rhesus positive, because of the same reasons as said before, there could be interchange of cells between the fetal and the maternal interface, and rhesus positive cells could come into the mother's circulation. Now, when rhesus positive cells come into a rhesus negative mother, she develops antibodies against them, and these antibodies stay on for a long time. So, if the mother has become isoimmunized and she is going to get pregnant again, we are really worried, because if this time she has a rhesus positive baby, that baby can have severe anemia and there could be erythroblastosis fetalis. So we follow these mothers very diligently, and we keep doing MCA Dopplers so that we detect fetal anemia at the earliest. But suppose we had a mother who was isoimmunized and we could tell her that the fetus she has inside is rhesus negative, a lot of problems could be undone very early. Also, if we knew that the fetus is rhesus negative, we would not unnecessarily give her antenatal anti-D. So, using cell-free DNA in this scenario is very realistic and is very helpful, as in it avoids unnecessary testing and stress. So, there are studies which say that it's very effective, cost effective, as well as very beneficial. In India, we still have very limited access to this kind of testing, because most companies that offer us this test don't actually offer rhesus typing in the fetus, but I'm glad that a few of them are starting to do it, and we hope that we will have more and more access to this test, because it is going to help us. Because when we focus only on Down syndrome, it understates the fetal observed risks. It is a very non-invasive prenatal screening is a very good screening for Down syndrome, but very expensive as a primary screening tool. And it's very driven by sort of industry, where we see that a test with a lower detection rate and a higher cost is taking over a test with higher detection rate and lower cost, with this perceived sense of security that there is no added risk of miscarriage. So, at the end, cell-free DNA is a prenatal diagnostic test. It's used to screen for fetal trisomy 13, 18 and 21 with a very high sensitivity. It's used to guide management in rhesus D negative women who have fetuses at high risk for hemolytic disease of the fetus and newborn. And it can be used for fetal sex determination where clinical indications exist in pregnancies that have a high sex-linked genetic risk. The options of doing genetic analysis from the cell-free fetal DNA for thalassemia and other mutations is still under research settings because we don't have it validated for general commercial use. So, it is a screening test, and because of the potential of being able to detect the prenatal fetal sex, PCP entity forms have to be filled. Now, do you still need to do scans after you have this? Yes, very much, because do not forget that viability, location, dating a pregnancy, single or multiple pregnancy, structural fetal problems, cervical length, growth disorders, general well-being and timing obstetric decisions are all important. While this is an excellent test to rule out one aspect of problems in pregnancy, let us not forget that all the other problems are staring at our face every day much more than the risk of trisomy 21. So, screening tests look much beyond aneuploidy. So, one test which only tells you about the number of a few chromosomes cannot be the panacea of all screening problems. Because someday you will have Mrs. Someday visit you, who's 37-year-old, gravida 2, para 1, L1, who comes for an anomaly scan at 18 weeks and had cell-free DNA done at 10 weeks because her obstetrician gave her the best possible screening test at that point. But at the 18 weeks anomaly scan, you have bilateral cleft lip and palate with a unilateral clubfoot. And then the fetal medicine doctor says, now you need to get a karyotype done. And then she's all lost, confused, bewildered, and she says, why do I need another test? Why didn't my doctor tell me about this before? So, if only we had talked well and explained to her all the limitations. You said cell-free fetal DNA was good. It is the best screening test, but yes, but there are limitations, and it does not tell us about other chromosomes and also translocations. So, that's the other part of your counseling, that when you tell them that we are ruling out something, we are only ruling out trisomy 21 to a large extent, but other problems could surface later, and despite having a cell-free fetal DNA test in the first trimester, you may end up needing invasive test for fetal karyotype later, because some indications may arise later. So, this is an excellent article which I think all of us should go through. It's published in the Journal of Fetal Medicine, the Society for Fetal Medicine Journal, in March 2017, where Professor I.C. Verma has taken a lot of trouble of putting this American College of Medical Genetics 2016 update on non-invasive prenatal testing for fetal aneuploidy and its implications on Indian population. And he has addressed all these issues like pre-test counseling and gestational age implications. The turnaround time of this test is about 10 to 12 working days, and if the screening results are high risk at 19 weeks, in India we have a gestational age based limitation for this test. The option to do other trisomies, what is the relevance of doing trisomy 13, trisomy 16 or 22? Is it really useful in adding that to the armamentarium of cell-free DNA? What about the no-call issues? Because there could be failure in getting enough fetal fraction, and hence you may have to repeat the test, and that increases the turnaround time and the level of anxiety. Fetal fraction issues, whether all labs are following the recommendations and reporting their fetal fractions so that we know that the values that they are giving are valid, and the use of these microdeletions like we've discussed before. So, can we use cell-free fetal DNA better? Of course, we can use it better, because there are many things that we are doing well right now, but we can fine tune our indications, we can use it in the correct time on the correct patient, we can increase the indications of doing cell-free DNA to more relevant areas like rhesus typing and screening for other genetic conditions where somebody is high risk because of an X-linked dominant or recessive condition. So, those are the things which we can do better with cell-free fetal DNA. However, it's a very strong and potential test for clinical use, and unless we use it on the right indication and the right patient by the right doctor in the right time with the right technique and follow up, it can be that you've given beautiful colors to a set of amateurs who are just scribbling on a painting screen, whereas if you gave it to somebody who knows how to use it properly, these colors could actually get organized better and end up in a very good masterpiece. So, of course, you can do better with cell-free fetal DNA. So, do the best until you know better, and when you know better, do better. Thank you very much for a very patient hearing, and let's have some discussion and questions.
Thank you very much, Doctor, for the great knowledge that you have shared. There are some questions which have come across. So, first question is cell-free DNA cost effective when applied to low-risk population?
No, we just discussed that. So, in a traditional low-risk population, cell-free DNA would not be a cost-effective option because it's too expensive and it gives very limited information. So, in a low-risk population, you would want to use a screening test that would provide you much more relevant information and at a lesser cost. So, comparatively, if you do a NT scan with the combined biochemistry in the first trimester, you are getting information about the structure of the fetus, aneuploidy markers of course, and in the biochemistry you are getting not only risk for aneuploidies, but also the extended biochemistry now addresses the risk of preeclampsia, and the advantage is in the first trimester you can use disease modifying drugs and alter the disease profile of preeclampsia. Then it could also give you a warning sign for the presence of fetal neural tube defects. So, combined screening strategy in the conventional method has many more advantages when applied at the population or the low risk level. The cell-free fetal DNA technique should be used specifically for that high risk group which has been classified as say high maternal age above 35 years, the previous child with a trisomy 21, or somebody who has a translocation in chromosome 14 and 21 and therefore very, very high risk of having trisomy 21 again. So, for that group, using it as a primary screening strategy makes sense, but not to the complete population. So, there are some other questions here. Should we have an option for only trisomy 21, looking forward for a guidance criteria to look for trisomy 21 only if parameters so selectively chosen as per you? I definitely feel there should be an option for that, because the group that we just discussed, they are high risk for trisomy 21, and if we could rule out trisomy 21, then trisomy 21 screening is done. What we need to understand now that prenatal screening has become wider. It is not just Down syndrome screening. So, prenatal screening, the purpose and the remit of prenatal screening has increased to screening more for maternal complications. See, now we all are very well aware of this concept of inverting the pyramid of antenatal care, where the chunk of maternal fetal screening is done in the first trimester. And Down syndrome is a very, very small aspect of that entire screening. For some reason, we have focused too much on Down syndrome and we've forgotten that our risk for pregnancy complications like preeclampsia, the risk for structural defects in the fetus, the risk for even hemoglobinopathies for that matter, they are all realistic risks, and they will bite us sometime or the other if we don't pay attention to that. So, if there is an option of doing only trisomy 21, I am hoping it's cheaper than the present costs of cell-free DNA, and that will make a lot of sense to use it in a given population. For the rest of the people, our conventional screening strategies, which are getting better and better every day, should be the primary method of screening. Could you suggest the lab that looks for fetal rhesus status by cell-free DNA? I know for sure that Sir Gangaram Hospital in India does offer it, but you have to contact them and they have some limitations on how to collect the sample. You can contact them directly and they will be able to help you. The commercial labs, as I said, it's an outsourced service, so we have to just contact them and they will make it available through some of the other lab outside India. Do you use cell-free fetal DNA for twins? Again, not routinely, but we have done 2 cases of twin pregnancies recently, because they came high risk based on their conventional screening, and they were IVF pregnancies and they were completely scared of the risk of miscarriage. They did not want to have an added risk of miscarriage by invasive procedure, which is definitely higher in twin pregnancies as opposed to singletons. So we did use it in twins, and luckily our results were low risk. We are still to wait for the results, but the technology is now validated for that, and there is literature to say that it's good. It's a valid method for trisomy 21 screening. I feel the intermediate group after combined FTS can be offered NIPT. Yes, I mean the low risk group need not be offered NIPT is what is the message. The intermediate or the high risk group, that will be a protocol based decision. Some people send the high risk group directly for invasive. Some people use lower cutoffs for the intermediate and high risk groups, and therefore they expand the use of cell free fetal DNA, which is both valid. How much time it takes for the final report? The final report comes in about 10 to 12 working days. So you can tell the patient 2 weeks max, and in 2 weeks we usually get the report. There is about 5% recall rate because they are unable to get fetal fractions, and it's actually these IVF pregnancies where the PAPA levels are very low, where for some reason the placenta and maternal interface is not so sturdy, that is where you get a very high recall rate. So the anxiety continues for a very long time. But since the anxiety is about not having a miscarriage because of an invasive procedure, people tend to accept that. Earliest at what gestation we can do it, and any lab doing it in Gujarat? We can do it as early as 10 weeks of pregnancy, not earlier than 10 weeks. After 10 weeks of pregnancy, anytime. Several labs are offering it in Gujarat, and I don't think I should be naming labs here, but I'm sure a lot of labs do. I know for sure that Gujarat has also some of the best rates for NIPT because they do it in conjunction with their medical college faculty, and I think it's because the volumes are high that the price that it costs for an NIPT in Gujarat is much cheaper than in the rest of the country. So yes, there are. Maybe I could send you some details. Thank you, Rajesh. And what is the cost for this test? How can we get it done in a really deserving case? The cost for this test actually varies from lab to lab because some of them they claim that the technology they use is better, the thing. So as a ballpark figure, anything from say 15 to 25,000 is the range at which we get these tests, and you can contact the labs directly. And most of these labs, they have people who can collect samples from anywhere in the country actually. So we could give you that information as you need it. What is the role of GC content in detecting trisomy 18 and 13 through cell-free DNA? Well, that's a very technical question, but I know for sure that the methods of detecting trisomy 13 and 18 are not as robust as the methods of detecting trisomy 21. That will have to be addressed by somebody who is a very biochemistry or a lab person, that they would know what is the difference in the ATGC content in all this. I don't find myself competent in answering that question. I'd probably ask somebody from the lab to get back to you. Some labs proclaim the use of cell-free DNA in detecting microdeletions. Is it validated? No. I mean, the validation is still very premature, and see, it is like they have some DNA and they are playing around and looking at as many things as possible. So maybe with time we'll get better validation. Currently the reports mention clearly that it is not validated information, but because they've looked into it and not found anything, they give it to us as a sort of reassurance. If we find regular microdeletions and then we can reconfirm it based on direct testing, then we'll have more evidence for it. At this stage, I think our experience altogether is very premature in this, at least in India. Thank you. What is the basic principle behind NIPT? The basic principle is that some fetal cells migrate into maternal circulation, or some fetal cell, and they are broken down in the maternal circulation, hence their DNA is circulating freely in the maternal circulation, or the cells are broken down in the fetal zone only by apoptosis, and the DNA migrates into the maternal circulation. So, either which way you have a chunk of cell free DNA in maternal blood. So, you are retrieving maternal blood by a skin puncture, which is like any other blood test, but the information that you are getting that is revealing something about the DNA composition of the fetus. So, if you get a high risk for an aneuploidy, the chances that it is from the fetus are very, very high, although it is not 100%, and hence it is only a screening test and not a diagnostic test. That is the basic principle behind NIPT. We are running short of time, we are drawing this session to a close. Kindly get your queries answered quickly. Okay. So, thank you very much all of you.